Good evening and welcome to our webinar tonight. I am Wendy Golden. I'm an endodontist and medical affairs for Endo. Tonight we are going to learn quite a lot. We're going to start with how to learn how to identify the role of systems in efficiency. How do we schedule? What are clinical and technology-based systems function, and what is the backbone of workflow efficiency? We're going to learn how to integrate technology into a systems-based approach. How does GentleWave work in that environment? What are the positive feedback systems that reduce our chair time for our patients, ourselves, improve our patient outcomes, and minimize postoperative pain? And then we will learn how to apply these practical strategies for our staff and workflow optimization. Tonight's webinar does include 1.5 CE credits. How that works is you must be individually registered for tonight's Zoom. Your attendance is going to be recorded. We want to make sure that your full name is under your picture, and if it's not, if you want to put that in the chat and let us know, we would appreciate that. We're going to send you a survey via email. We ask that you fill that out and then get that back to us. After we receive that, we will send you an email with your CE certificate. If you have any questions along the way, please reach out to myself or education@sonendo.com. So tonight should be very interactive. Your questions are deeply encouraged. During the hour presentation, we ask that you place them in the chat box. When the presentation is over, you're welcome to come off mute, hopefully off camera, and ask the questions yourself, or I can ask them for you. So it is my pleasure to introduce you tonight to Dr. Jonathan Uhles. Dr. Uhles graduated from the University of Tennessee College of Dentistry. He practices at Cumberland Endodontics, which is very close to Nashville, Tennessee. Dr. Uhles has been using GentleWave since 2017 and has completed over 7,000 GentleWave cases. So now is the time to ask questions. Thank you for tonight, Jonathan. I'm going to turn it over to you.
All right. Well, thank you, Wendy, for that wonderful introduction. Give me just a moment. We'll get our screen sharing here and get going. All right. So tonight's lecture, we've got a lot to cover. This is something I'm incredibly passionate about. This lecture, Efficiency Reimagined, is really about redefining how we look at the modern endodontic workflow. A couple of housekeeping items right off the bat. First and foremost, the opinions that I'm going to give tonight are my opinions. They're not reflective of Sonendo. I am being compensated for my time to give this lecture as well. So I thought we would start here with a story from Greek mythology. And in Greek mythology, we hear the story of Icarus, the boy who strapped on wings of wax and feathers. He soared into the sky and ignored his father's warnings not to fly too close to the sun. You see, he believed he was invincible, and for a moment he was. But as you can imagine, the wax melted, the feathers scattered, and ultimately his fall was fatal. And when we look at these myths, they aren't just old stories. They're actually warnings disguised as wisdom for us. And like Icarus, when we buy into modern myths about work, efficiency, or success, the consequences can be just as real. The question is, which myths are we believing? How high might they take us before we fall? And is there anything that we can do to prevent that from occurring? And so, one of the most common myths that we have in dentistry is this one. It's this idea that faster is better. If we can just work faster, we're going to be more efficient at our job. And the reality is, you can't work faster. That handpiece is only going to run at so many RPMs. And these are our rate limiting steps. And a lot of times, our desire to be faster actually is going to create more inefficiencies and it might create more problems for us. And I put together a list of some examples. Now, we're not going to go through all of these, But if we do just a few of them, let's pick instrumentation. So if we try to instrument too big, too fast, without a proper glide path, we know that the repercussion is probably instrument separation, ledging, transportation, maybe the need to spend more time trying to retrieve or bypass that file. And then we're burning into our time and our stress and anxiety level is going to increase. So again, our effort to try to do something faster actually slows us down in the long run. And I get it. The modern endodontic challenge feels harder and harder because we're dealing with staffing shortages and turnover, increased patient expectations, decreased insurance reimbursements, burnout from production, rise in complexity of our cases, unpredictable schedules, and then this, rise in medical and dental litigation as well. And Sorry. And this is really where our systems come into play. And I don't want you to think about systems as being a micromanagement tool, but rather as a freedom framework. Because really, it's our systems that are going to liberate our mind, they protect our energy, and they deliver predictable excellence for our practices. So, again, today I want to challenge you on this idea that being busy means being productive. Because in the modern endodontic practice, efficiency isn't going to be your hustle, it's your design. It's creating a system that works for you, but it also has to work for your team. And that allows you to take control of some of that chaos. So, where are we going to go in this lecture tonight? Well, we're going in three places: scheduling systems, clinical systems, and gentle wave systems. So, let's jump in. Sorry, guys, hold on just a second. Okay. So, Atomic Habits by James Clear is one of my favorite books. And if you haven't read this, I strongly encourage you to do so because it'll really change your perspective on so many levels of your daily practice and life. But in this book, this quote really stands out. You don't rise to the level of your goals, you fall to the level of your systems. I'll read that again. You don't rise to the level of your goals, you fall to the level of your systems. And this is where I think so many practices and talented clinicians really fall short. It's not that they're not incredibly talented, it's that they don't put in systems that are actually going to drive their productivity and their efficiency within their practice. And a big part of that is actually our scheduling systems, because these are some of the most critical. And it's one that had the largest impact on our practice outside of incorporating the gentle wave system. So some of these concepts that I'm going to give to you are going to be controversial, but I can tell you from experience that once implemented, they really increase your efficiency, your productivity, and they create a flow in your day-to-day operations. And anyone that has come to our courses, we do courses at Cumberland Endodontics on this. When they come in, if they take nothing away from the course, aside from what we recommend in scheduling, we hear back from those people and they say it's one of the best decisions they ever made. Now, if I asked most of you how you feel throughout the day right now, I would bet you would probably empathize with the image that's on the screen because you're probably feeling like you're a puppet being controlled by the chaos of your own office. And this is honestly how I felt prior to the fall of 2017. I graduated from UT in 2014. By the time the summer of 2017 rolled around, I was miserable. I was absolutely burnt out on private practice. And I can remember this really visceral moment of being in the office late one evening. I'd been there since 7:30. It's 6:30 at night. I stayed late to see an emergency patient. I haven't had dinner and just breaking down in tears because I didn't know if this was the life I wanted for myself. And I think if we look, a lot of people feel that way. And what makes us feel that way is that we're not in control. And that really comes down to not being in control of that schedule. So instead of letting the schedule control us, we need to take control so that it's not destroying us both mentally, emotionally, and physically. And if I ask the majority of you in this chat how you practice, you're probably going to say this: the meet and greet and treat. I call it the scaries. It actually terrifies me. So you're seeing the patient today, diagnose the problem, you go ahead and treat it, maybe in 1 to 2 visits, collect the fees, tell the patient to come back in a year for a recall. And that's how the majority of endodontists practice. That's how we practiced prior to 2017. Now, one thing I'll tell you is that we track everything in our office. And when we looked at our numbers, what we realized was 30% of the patients that were coming into our practice on a consult start or meet and treat basis, 30% of those were no-goes. So that's wasted, unproductive, inefficient time. And this is where GentleWave really gave us an out because the initial recommendations back in 2017 when we were adopting it was essentially you were supposed to take a pre-op CBCT to determine if the case was suitable for a gentle wave, and then there was this whole laundry list of contraindications. And so for us, we use this as a way to model a new schedule for our practice. And in that consult start based model, there's a lot of roadblocks that we're going to face. Number one, patient willingness. Maybe the patient requested a consult start, but then they get there, and my favorite, phrase was always, "Oh, no, 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 I'm not mentally prepared for that today." Or maybe you get there and realize you've got a split tooth scenario, or a vertical root fracture, or a non-restorable tooth. Well, that's wasted chair time. Or maybe you realize this patient is highly anxious. They need some type of sedation. Maybe they're claustrophobic and they can't tolerate the dental dam. Maybe it's an issue of money. They just don't have money to do treatment that day. They weren't aware of the cost. They weren't aware of how little their insurance covered. And then, of course, my all-time favorite, which is the middle finger to your day, the no call, no show on the patient that confirmed their appointment. So, in my opinion, this model of practice creates a lot of lost income, but it's really breeding anxiety, uncertainty, burnout, and it can also drive unethical procedures for the sake of production, especially with the rising cost of dental school and our office's expenses. So, how can we eliminate this uncertainty from the schedule? And for us, that answer was to create a system to basically triage our patients and ensure we had adequate time to meet the patient and really make sure that they were a candidate for the gentle wave system. So in the fall of 2017, in addition to bringing the gentle wave on board in our practice, we immediately switched over to this consult-based practice model. And this is essentially what that looks like. So basically the patient gets scheduled for a consultation, their arrival in the office, and then registration. And one thing I always tell people is make sure that you are strongly pushing or encouraging that patient to do the registration prior to their arrival. Office time is chair time, not registration time. So we want that registration done before they get in the office. And again, we have policies and procedures in place to drive that compliance. Then the assistant is going to bring that patient back, do all the initial pre-op imaging. They're going to obtain a detailed history and do all the diagnostic testing. And people always were like, you let your assistants do the testing? Absolutely, we do. Why? Because we've trained them to be confident in their decision-making process. I would honestly put their skills up against many clinicians I know. So again, if you put the right policies in place and you can train them, this is something well within their scope of practice. Once they've assessed the case, they're going to come in and present it to us. We're going to verify those findings by going in and meeting the patient. And then a good portion of my time in the room is spent educating the patient. So I'm talking to them about what a root canal is, what gentle wave is, what sets gentle wave apart, what's the prognosis for their case, what does the follow-up look like for their case. And then if the patient is on board and they want to proceed with treatment, great. We do a pre-treatment estimate, and then we're going to take a pre-op CBCT, and this is going to be required before they're scheduled. And then ultimately they'll go up to the front and be scheduled for their appointment. And so really what this model or practice does is it reduces our stress because now we control all the variables. I'm not worried about if the nice old lady down the street is walking into the room and I'm going to be doing treatment. So I'm not under this time crunch, and I have time to be with that patient and to really diagnose, educate, and then also perform emergency-based care if needed. And this is a big question we always get. What about the people that are in pain? We need to realize that putting burr to tooth is not always the right answer. If someone is swollen, do an incision and drain them and place them on an antibiotic and bring them back in a day or two. If it's a pulpitis case, place them on steroids. There's nothing wrong with putting that patient on a steroid. 90% of them are going to feel better within 24 hours. More importantly, we know that steroids are one of the few things that will increase our success rate for those hot lower molars. So, why would you not put them on a steroid, bring them back in 24 hours, have less problems struggling with anesthesia, do the procedure and make it an easier, less traumatic process for the patient? So we can accomplish those same goals with a lot less trauma to the patients without putting burr to tooth. So that's the overall schedule. Now I want to shift gears at this point. We kind of talked about the overall schedule. We've made some efficiency changes there, but it's only part of the equation that leads to our overall solution. And hopefully everyone recognizes this guy. This is Benjamin Franklin. And while most of you probably know him as one of our founding fathers, you may not realize Benjamin Franklin was one of the earliest people we know of that used this idea of time blocking. And Franklin was very, very meticulous about this. I mean, he laid out when he was going to work, when he was going to sleep, when he was going to read. His day was very, blocked and consistent in what he was going to accomplish. And if it was good enough for him, why is it not good enough for us? So we should be blocking our schedule to make sure that we're being as efficient as possible. And I kind of laid out our schedule showing you what that general time frame is. So treatments are about an hour and 10 minutes, and then our consult is a 40-minute process. And if you look, this isn't typically on the schedule, but you can see all of these individual blocks laid out. So for that consult, the first 20 minutes of that appointment is basically the workup by the assistant. The next 10 minutes is basically for me to confirm and do the Q&A session. And then the last 10 minutes is the estimate, the CT, and then the appointment scheduling. If we're doing a treatment appointment, it's basically seat and prep. That's the assistant role. I come in 10 minutes into the procedure, approximately 20 minutes for anesthesia access and instrumentation, 10 minutes for gentle wave, 10 minutes to obturate and temporize, 10 minutes for restorative. I leave the room, and then the last 10 minutes is post-op and dismissal. And then as I leave the room, I'm going into my next consultation. So, how does this work? Aside from the time blocking principle, there are really three key concepts that, come into play, and we need to be aware of them as we're creating this time block schedule for our practice. And the first one of these is this idea known as Parkinson's Law. And some of you have probably heard of this. When I was at the University of Tennessee, my chairman, Dr. Adam Lloyd, he beat this idea into our brain. And, simply put, Parkinson's Law states that work is going to expand to fill the time that we give it. So if you set a patient procedure for 90 minutes, guess what? You're going to spend 90 minutes. But if you tighten that frame down to 60 minutes with the right systems in place, then suddenly your efficiency is going to kick in. Your deadline is going to create the focus. And with that, without that, time is just slipping away from us. And in our office, like I said, we set that at 70 minutes for a gentle wave procedure. We don't differentiate between tooth type or case type. We actually just use that as a baseline. And for me, what I do is I use this almost like a race. So I'm essentially racing against that block, not to provide subpar care, but to see how fast and efficient I can actually be. And my staff know that when we sit down, it's go time. So even if we've got 70 minutes blocked, that doesn't mean we're going to use the 70 minutes. If we're doing an anterior tooth or a maxillary molar with no restorative component, then they know I'm probably going to be done in 30 to 40 minutes. So what does that do? That gives them the flexibility that they can add a consult in, or depending on the case type, we can add an emergency or do an entire gentle wave procedure in that time period. So again, this is one way using Parkinson's law that we can drive that efficiency and kind of race against the block that we're creating for ourselves. Concept number two, this is attention residue theory. And this basically suggests that when you switch from one task to another, a portion of your attention is going to remain stuck in that first task. And this was shown by Dr. Sophia Leroy in 2009 in her studies. And even with this slide, as you're trying to read these words, they're separated. And because they're separated, it's creating stress for your brain because it's trying to process each of those individual words and then put everything together as a whole. And the residue reduces your focus. It's actually going to slow your performance and it's going to make you less effective at a secondary task. And this explains why multitasking and rapid context switching feel so mentally draining to us. So, during the day, if you're constantly being interrupted by your staff to deal with a management task, being asked questions about your schedule, if you're responding to constant emails or text messages, or engaging in social media, guess what? You're going to have a more difficult time focusing and you lose efficiency. And this isn't just me saying this. This has been shown in several studies at this point. As you switch tasks, your efficiency is going to drop. So we really want to try to stay on point. Now, if I had to ask you guys to guess what the number one distraction at work is, I'm sure you could all guess. It's our smartphones, right? So, smartphones are a huge obstacle, and there's a lot of studies saying that now most workers are losing about an hour and a half per day because of the distraction related to a smartphone. So when I get to work, the very first thing I do, I go in and I reduce interruptions using Apple Intelligence. I'm going to cut off all distractions. If you're one of these people that you're still going to be tempted, invest in this device called a brick. You can literally, I've got one of these at home, I've got one of them in the office. When you walk into work, you can tap your phone against that brick and it will lock it down. So the only thing you can do is make phone calls. Now, I have more self-control than that, but we do have it available if someone wants it in the office, and you can use it to your advantage as well. The other big thing that I try to make sure our staff understands is that our time is valuable. And again, our focus should always be on patients. So in office, I try to encourage the staff to not disturb us during the day. If I'm in our office writing a letter or taking a call, that's my time. So if they need something, what we did is we actually instituted this, which is basically a board. They can come in and they can write down, need you to read a CT on blah, blah, blah. I need an anxiolytic called in for this patient. I need a referral letter for this patient. So anything that goes on the board is there. If I have time during the day, I might address it, but for the most part, I tend to address that at the very end. Again, that way I'm not switching tasks, I'm not losing focus throughout the day. And then concept number three is decision fatigue. And decision fatigue is basically just mental and emotional exhaustion from making too many decisions throughout the day. And this is where blocking your schedule really becomes an advantage for our staff members because it's a plug and play format for them to follow. There's very little thinking required, which is good because we're asking them to do a tremendous number of tasks at the front desk. But it also means that you're not going to be inundated with scheduling questions. So you give them the playbook and then you're going to empower them to make those decisions on behalf of the practice. But with that, it's not just about, blocking your treatments, block management tasks as well. So management time and clinical time should be very separate tasks and they should not intertwine. So from, 8 a.m. to 4:45 p.m., my focus is on patients and patient care and nothing else. So unless our building is on fire, there's a real emergency, I don't want to be bothered. So minimize the decisions that you have to make outside patient care. Now, for me, I'm a morning person. So, I typically block this on my schedule. I'm at the office at 7:20. That's when I do all my management related tasks. And then I have one Friday a month that I block for larger HR tasks and, office planning. So again, plan that stuff so it's not constantly interrupting your day and dropping your focus, thereby reducing your efficiency when you're trying to provide patient care. So quick summary here on our scheduling systems. First and foremost, the myth of that consult start. Two, consultations will decrease uncertainty and reduce stress and anxiety. They're going to increase predictable production for us. Number three, care isn't limited to the burr and tooth type procedures. Number four, create a schedule that works for you, your goals, and your well-being. Number five, Parkinson's law. The task is going to expand to fill the time allotted. Race against yourself. Time blocking is going to drive your efficiency and reduce attention residue and decrease decision fatigue. And then reduce interruptions and drive efficiency. And then finally, schedule everything. It seems silly, but again, time block and schedule everything. All right, let's talk about clinical systems and specifically what are the things that you can do that will drive a more streamlined and efficient chairside procedure. So, very famous quote from Socrates, and that quote is this: Know thyself. And clinical efficiency really starts with an honest self-awareness. So, recording your procedures with a video camera, GoPro, through the microscope is going to allow you to identify dead space, redundant movements, and inefficiencies that are otherwise going to go unnoticed. And this is something I picked up from Dr. Gary Carr. It's one of the best things that I've done for myself and for my practice. Socrates would say that unexamined life is not worth living, but for us, I think that concept should really be that an unexamined procedure is not worth repeating. So look at your process, look at your procedure, and really see, where's the fluff. And when you're reviewing this footage of yourself, always ask yourself at every moment, is this necessary? If it's not contributing to the process and the efficiency, eliminate it. There's no reason to do it. Get rid of it. And again, this is something I've done multiple times. I continue to do this in our practice and with our staff. I can't tell you how much more efficient this has made me as a clinician. And then using these recordings as a mirror for personal growth and refinement is really, it's rewarding. Not only that, but you can use it to drive training for your assistants. So this is Michaela. She's one of our more green assistants, I would say. So she's still in the learning process. We record the video, we play it back, we show her where the dead space is, how she can be more efficient. And then again, we're using that as a training tool to make sure that our assistants are in line and following the protocols that we expect. So we know where our inefficiencies are, but we can't stop there. We need to know our numbers. And so when I talk about our numbers, I'm basically talking about our time. And this is really where time motion studies come into play. So this is used heavily in the manufacturing world, especially in industries like car manufacturing. And really what they're doing is they're analyzing the efficiency of the procedure down to seconds. Now, we're not necessarily going to do it by seconds, but the overall goal here is, it's a method for gathering data about a clinician for a procedure and breaking the parts of the procedure down into individual time increments. You're going to do an average and then figure out what the percentage of that total procedure is for that. So this is essentially what this looks like. This is one of my own time motion study templates. And you can see here, this is a molar root canal with restorative. So we do a large percentage of restorative cases in our office, basically the core buildup or the post and core for our referring doctors. So regardless of the molar, type, maxillary or mandibular, I don't really differentiate, but what's my average time for anesthesia, for access, for working length, for instrumentation, gentle wave, and so on. And this is so good. I know these numbers like the back of my hand. I know that if it's a molar procedure, I'm going to be building my gentle wave platform consistently right around the 18-minute mark. And this is a really valuable tool because, again, it's going to help us to create the appropriate time blocking versus having wasted time within that period. So now the next clinical recommendation I want to make for you is probably a little controversial as well. And this is this idea of co-observation. And I know a lot of endodontists do not do this, but I think we need to view our assistants not just as helpers, but as true clinical partners. So by co-observing under the microscope, what it's going to allow them to do is really anticipate your moves and reduce some of the verbal communication lags that can occur. So just to kind of review that and give you a couple of examples, it's real-time co-learning and anticipation. So the assistant can see my field of view. They're going to gain a deeper understanding of the anatomy, the instruments, the procedures in real time. And then it allows them to anticipate the next move rather than waiting for your verbal cue. So, for example, if I'm working on a case, as I pull a file out and they see that it's unwound, I don't have to ask for that same file. They're going to automatically grab and have a new file ready for me to go. Or if they're watching me move the files through the canals and noticing that I can't get a 1704 to patency, what are they going to do? They're going to grab a 1403 before I ask, put it on the sponge, and have it in my field of view so I'm ready to take that. So again, it's going to be faster communication. It's going to enhance your training and development of your assistant. It's going to create an improved workflow rhythm, but it's also going to create a stronger team and more engagement. And if your assistant feels valued on that clinical process side, they're more likely to have job satisfaction and really stay and be a retained employee, which is really what we want. We want to create a cohesive team that works together and has that family feel and drives that efficiency process. And then number four, if you haven't already picked up on this, it's going to be policies and procedures. So, core message here is a manual isn't bureaucracy, it's a stress reducer. And clear expectations are going to shorten that training curve and prevent the chaos of tribal knowledge. And if used correctly within your office, it can actually drive your efficiency by increasing staff competency and reducing the QA about various situations that may arise. So, view your policies and procedures. They should really be the why and how of us. That's the best way to look at your policies and procedures. So you're basically creating a clear standard of expectations within the office. That's the policy. And then the steps to ensure the desired outcome. Those are the procedures. And I would encourage you to standardize everything because by standardizing everything and having a office policy, your manual, your employee manual, we have policies for everything. We have policies and procedures for a time request off, for patient registration protocols. And this really protects the business against staff loss, but it also creates a very consistent path that the staff can follow. So there's very few questions being asked. They know I have to do this because, and these are the steps. And then, review this periodically with the staff. We'll bring it up randomly in our staff meetings and say, today, we want to pull up and just review this policy with everyone. And a part of that is also incorporating things like checklists. And if you are not doing this now, please, 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 please do this with your staff. The book, The Checklist Manifesto, is wonderful. I love this quote. It is common to misconceive how checklists function in complex lines of work. They are not comprehensive how-to guides. Whether for building a skyscraper or getting a plane out of trouble, they are quick and simple tools aimed to buttress the skills of expert professionals. And I love that quote because it's so true. When we put these things out, these checklists in our office, we're not creating a crutch for our staff. We're actually just buttressing their skills and we're creating reliability. So for us, from sterilization protocols, how do you, arrange a cassette before it goes in sterilization, the room setup and the responsibilities and the maintenance tasks related to the office and GentleWave. These checklists are there to reduce human error and increase our efficiency while also protecting us from liability concerns. And then clinical tip number five is this one. I would say take this one from the Boy Scouts. Be prepared. So, what I mean by this is before you ever step foot in the room, you should be prepared for that case. And this is really where the value of the consultation comes in before treatment, because that's our time to really prepare plan out what we're going to do so that we're not missing anything. And how do we do this? Four critical things. Number one, meeting the patient well before treatment. So listen to that patient, really understand their concerns, judge body language, and determine if you need to alter your treatment approach. Because, again, if someone's coming in with a high level of anxiety, I'm automatically going to recommend they take an anxiolytic or we consider some type of sedation for that patient. My job as an endodontist is to manage the endodontic problem, to prevent or eliminate apical periodontitis. We are not psychologists. Our job is not to manage someone's psychoses. Yes, we can be warm and inviting and caring, but if they're going to make our primary objective harder, then we need to be prepared to institute a policy that will make it more predictable. And that's where those anxiolytics come in. Same thing, if you're not showing that patient a dental dam before you do the procedure, and then you go to put that dental dam on and they panic, again, lost and wasted production. So this is where the consult comes into play. Number two, I always talk to patients about outcomes, success rates, and failure rates based on literature. But I also talk to them about their own comorbidities like diabetes and smoking and autoimmune disorders and chronic pain disorders and how these things play out, how they may affect not only the success rate, but the post-op recovery. And this is something I learned from Dr. Kyle Stanley, where he said a lot of times dentists, our problem is that we don't lay these things out for patients. And then if they do come back with a problem or they're struggling, then it sounds like we're making an excuse for why. So again, if you lay out the possibilities and have the patient engage, it's going to create less issues in the long run. So it's going to reduce your chair time and drive that efficiency. Number three, in our office, we use yellow notes or this, feature in TDO. If you don't have TDO, there's probably something in your software, but, I always review that case and I list anything special outside the norm so that the staff is prepared for it. What I don't want them doing is the day of the procedure, trying to find something at the last minute. So if it's a case, like this one we were dealing with, I put in there, patient's a severe gagger, probably going to require Halcyon for treatment. This patient may have marginal breakdown. So I wanted them to prepare that we may be cutting off the crown, making a temporary, and removing any decay that might be present. So they have all those things out ready to go versus me asking mid-treatment and then they're struggling to find it. And then in the back of my mind, I'm wondering why they're not prepared for the case. Well, they're not prepared because they're not an endodontist. They don't know what to expect. So help our staff help us by making sure that they're prepared. And then the last part of this is just the CBCT. This should really be part of the standard of care, in my opinion. You can easily obtain your working length from this, know your danger zones, plan out that procedure. So I, measure off the CT. My first file in a tooth is going to be a DC taper 1403. So whatever I measured at on that CT, that's the length that that file is going to go to. And then my secondary file will go just short of that. Then I'll confirm my lengths with an electronic apex locator. So again, takeaways and summary there, meet the patient and know their needs. Don't be afraid to use an anxiolytic if needed. Set clear expectations about the case and the possible outcomes. It's going to save you a lot of stress in the long run. Communicate with your staff what you might need ahead of time, and then review that CT and use it as a roadmap. So number six is pre-endo restorations, and this should really be the norm, especially if you're utilizing GentleWave. And let me lay out the case why. So the pre-endo restoration is critical because with GentleWave, we have to have an adequate seal for it to work effectively. And if we don't, then what's going to happen is you're going to start that gentle wave procedure, you get marginal leakage, and then what's happens? You're going to get frustrated, you're going to push the gentle wave to the side, and then you're going to go back to your old typical habits. Again, that's not an efficient process. So with this, we can use materials like Sound Seal, which we're already going to have available for gentle wave, or you could do a glass ionomer, depending on how you're going to finish the case. So I just wanted to show you a quick example. This is tooth number 3. This was last week, diagnosed with symptomatic irreversible pulpitis and symptomatic apical periodontitis. So for this case, basically, I went ahead and removed all of the decay along the mesial wall. You can see the chamber's been accessed. There's fluid in here. Once I get all of that decay out, essentially what I'm going to do is dry or desiccate the dentin. We're going to put a small amount of bonding agent, just bonding agent on the dentin, light cure that. And then I'm just going to squirt Sound Seal interproximally. And it doesn't have to look pretty. We're using the other tooth as a wall. And then I'm going to use the perio probe to basically create an internal form. So internal within the chamber. Light cure that. And then I can continue to do my instrumentation and irrigation through that temporary Sound Seal matrix. Well, then when it comes time to do the gentle wave, guess what? All I've got to do is add more Sound Seal because it's going to bond to that material, and then I'm ready to go. I can gentle wave that case. But here's the best part of that. I'm not restoring for this patient. So when I take the platform off from gentle wave, because we bonded the initial Sound Seal layer, it's going to leave that there almost like a proximal wall. So now I can finish off my case, finish the obturation, I can do an orifice barrier, place, cotton or sterile sponge, and then cab it. And then all I've got to do is gently smooth up that proximal wall. And now I'm sending my patient out with a more predictable restoration that's got a little more oomph than just cotton and cab it. So again, that whole process, the initial portion is going to help drive our efficiency toward the end of the procedure. So a little preparation goes a long way. And clinical tip number 7, the elephant in the room with gentle wave is always instrumentation. And I really like to think about instrumentation as our dirty little secret, if you will. And what I mean by that is we know from our literature, despite our best efforts, regardless of the file system that we use, that we don't do a very good job of cleaning and disinfection. Study after study from Dalton to Paquet to Peters, they basically all show that we're going to leave about 29% of the canal volume packed with hard tissue debris. So pulp tissue, bacteria, blood cells, all these things are just smushed into that beautiful anatomy we're trying to preserve. And this idea that we can incorporate the original anatomy into our preparation is complete fiction. So purge that legacy concept from your mind because it doesn't exist. And this is really where we rely on our gentle wave system to help us overcome some of these challenges. So, this is the instrumentation setup. I don't want to spend a lot of time on this. This is my instrumentation setup for 90% of my cases. So a DC taper 1403, a DC taper 1704, and then I'm typically going to finish with either an endo sequence CM 2004 or a DC taper 2006. Now, with gentle wave, the thought process, of course, is instrumentation, less is more with this because the more we instrument, the more hard tissue and debris we pack into the anatomy. That being said, our goals are still bulk tissue removal and confirm a fluid pathway. What do I mean by bulk tissue removal? If I'm dealing with a palatal that's a 4006 to begin with, I'm not going to run a 2006 and think that I've removed adequate tissue from that canal space. So the overall size of the canal has to dictate the file to remove bulk tissue. It's not that gentle wave can't get rid of that tissue, it's that we don't have enough time to wait on it to dissolve all that tissue. So the more help you give it, the more efficient that process becomes. And then with instrumentation, really we need to reduce the total number of files. Again, you don't need to instrument more. You actually need to instrument less for the most part, which is going to save you time and it's going to save you money. The other big thing is reduce patency checks. Read your gentle wave protocol. It basically says patency one time. You get patency the first time and then you do not recapitulate. Your goal is not to continuously check for patency on those cases. And then finally, stop struggling with sharp curvatures or irregular canal anatomy. Your goal as an endodontist is basically to capture that anatomy that's there, patency is present and you're just trying to replicate it with a hand file. Sometimes you actually create more damage. So just get out of the way, let Gentle Wave work in those cases, trust it to do the job, and then the challenge actually becomes the obturation side of it. And that's not really something we're going to talk about tonight in this lecture, but that's really where we get to the nuts and bolts of how to really make Gentle Wave shine and work to your advantage. So a clinical case, this is tooth number 31. Again, just to show you, the largest file that went in this tooth, 2004 endosequence CM. There is no way that I touched that anatomy on the distal root. This is all that 2004 gentle wave, and then I use what's called System S, which is thermoplasticized injection technique to capture the anatomy that's present. And so the beauty of this is that we can trust this device based on the literature. So whether we look at Molina or Chan or Zong, we see very consistent results. In every paper, they demonstrate that gentle wave leaves about 97% of the canal volume empty. So removed of all the hard tissue and debris other than 3%. Well, 3% is a whole lot better than 29%. I know if I'm sitting down for a root canal, which one I want to be used on me. And just another case, again, showing you an example. This is tooth number 14. This was a SIPSAT case, so a vital case. And I was unable to instrument MB2. But what I was able to do is utilize GentleWave. So basically, I used a small file to open the coronal third of the MB2. I used GentleWave system, and then I used obturation methods to again capture that anatomy. And that's a 2-1-2-1 system. And again, this is very predictable if we're not destroying the anatomy and trying to capture it. So again, the less you do sometimes, the better gentle wave is going to perform in those cases. So again, quick summary of our clinical. Know yourself, record your procedure. I promise you, you won't be able to unsee your inefficiencies. Do a time motion study, figure out how long it takes you to do that, and then average that to create an appropriate time block. Use your policy and procedures to drive the efficiency of your staff in the office, and use checklists to buttress their skills throughout the procedure. Again, take one from the Boy Scouts. Be prepared before you step foot in that room. Use a pre-endo restoration. It's going to drive the predictability of your gentle wave process, and then it may increase your efficiency as well, depending on what your restorative protocol is at the end. And then instrument less. Embrace that gentle wave technology and trust it to do its job. And then last but not least, let's talk about gentle wave systems. When we talk about GentleWave, most of you are going to view this as just another piece of technology, but I really want to challenge you on that assumption. GentleWave shouldn't just be a piece of technology. You should use it and it should become a self-reinforcing system wherein the practice builds intentional processes around that. And what I mean by that is your gentle wave system should basically be like a flywheel. So once you set it in motion, it's gathering momentum and it's going to drive that efficiency, satisfaction, and then the overall ROI that you get on behalf of that gentle wave process. And this really begins with visibility and awareness. So your website and your social media should showcase gentle wave as a cornerstone of your practice. These are the components that your patients see before they call, and it's communicating to that patient that you're cutting edge and how you differentiate yourself from everyone else. So use this technology on your website and your socials basically to tell your story and why you deserve to be trusted and how you're different. And then hopefully from that, you're going to get a patient that's going to make a call. And that communication and that first contact is really, really critical. You know, the front office is essential because your scheduling coordinator, they're the voice of your office and your practice. And that initial interaction with someone will have such a huge bearing on your company and whether or not that patient decides to schedule with your office. So when they start to lay out the groundwork of your philosophy and your story and your basis for care, it's really got to be on point. Now, I wish I was smart enough to tell you that what I'm going to share with you is something that I came up with, But right after we instituted GentleWave, I was in our Cookville office one day and I heard Amber, one of our scheduling coordinators, say this to a patient. She said, "Your first visit will be a consultation appointment with Dr. Uhles. We've incorporated new technology into our offices to provide better treatment in less time. So that first appointment will see you for a consultation to diagnose your problem, discuss treatment options and finances, and determine if you're a candidate for the gentle wave procedure." And when I heard her say that, it literally gave me goosebumps. And you know why it gave me goosebumps? Because she planted a seed. Now that patient is automatically questioning, number one, what is this gentle wave procedure she mentioned? And number two, am I going to be a candidate for that? So after that initial phone call, use your patient registration forms and your welcome materials to highlight gentle wave again. So again, you're planning the idea that this is the standard of care in your office. So as part of our registration forms, we mentioned that we're one of the few providers in our area offering gentle wave, and we encourage our patients to go ahead and educate themselves by clicking the link to learn more. And even if they don't, remember, we have ample time during that consultation to educate our patient. Most of them are really hungry for knowledge. So I sit there and I discuss everything that I talked about. What is a root canal? What is the gentle wave? What's the difference between the gentle wave and a traditional root canal? We've got less post-op pain. We're saving more tooth structure. Um, there's if you're post-op complications typically, and then I let them ask questions. And a lot of times their response isn't a lot of questions. It's, wow, thank you for explaining that. I didn't know what a root canal was, and I've had four or five of them at this point. So, it's not that we're educating them because we want them to be aware again of what this is, what a root canal is, what the gentle wave is, because their perception of that is going to become important a little bit later. But not only that, by educating them and reinforcing this so much, what am I doing? I'm creating a system of accountability for myself because they know about the procedure. Now they expect it. So when it comes time to do treatment, I've got to deliver. That patient is expecting gentle wave as part of their care. So our assistants don't come to us asking, are we going to gentle wave this or is this going to be an endo activator? They know every case that we sit down for, it's a gentle wave case. There are zero contraindications, in my opinion, for gentle wave. And so when we go into the room, the console is primed, it's ready. The procedure instrument is typically already going to be attached and ready to go. The disposables are out and ready to use. And immediately after my last file, when we're instrumenting, last file comes out of the tooth. As I transition to give that to the assistant, she's passing me the sound seal at the same time, and we're starting to build our platform. There is no delay. This is like second nature and clockwork. Last file out, sound seal in hand. And then we start our gentle weight procedure. There's a lot of talk from clinicians about, well, it's a long procedure. It's 9 minutes. So 9 minutes of gentle wave total. So you've got 1 minute of a water leakage test, 5 minutes of sodium hypochlorite, 15 seconds of water, 2 minutes of EDTA, and then 45 seconds of water at the end. So, 9 minutes holding that can feel like an eternity for some people, but a lot can happen in 9 minutes. It takes 8.5 minutes for light to reach Earth from the sun. It took the space shuttle 9 minutes to reach outer space. So, if all of that can happen in less than 9 minutes, what can you accomplish during that 9 minute period? So if you are in a state that allows your assistant to irrigate, let them hold the gentle wave handpiece. This is prime time that you could step out again for that 10-minute period and go do another consultation, driving the efficiency and driving your production. Now, if you're in Tennessee like me, where you can't do that, guess what? We can still use that valuable time. I may not be able to get up and leave, but my assistant becomes incredibly efficient during this process. So what is she doing? She is finalizing all the documentation. She's sending all of our checkout notes to front. She's pasting all of our fees for that procedure. She's going to start to clean her space, prepare for obturation. She's going to pull out all of our paper points as well as our cones, and she's going to pre-measure them in an endo measuring block. Because when it comes time to obturate, again, we don't want dead space. What do we want? Clockwork. Every paper point is immediate, there's no delay. We don't want to waste time when we could have used that gentle wave time to our maximum advantage. So this is not dead time. This is actually valuable time. Use it to your advantage to drive that efficiency. And then the last portion on this is really patient experience. The gentle wave advantage, as you use it, it shows for itself. It's efficient and comfortable with a faster recovery process, less post-op pain, and fewer post-treatment calls. And, we have the data to back this up. So remember, I said we track everything in our office. So we looked at the 6 months prior to gentle wave and then the 6 months after gentle wave. And what we found was basically a drop in post-op pain from 31% to 6.7%. That's a big drop. That's fewer patients calling and fewer patients being seen for a check appointment. Again, driving the efficiency and the production, which is really our goal. And not only that, but one of my favorite things about Gentle Wave is really the almost complete elimination of endodontic flare-ups. So since 2017, I can literally count on two hands the number of flare-ups that I've had with Gentle Wave. And again, that's a huge, huge time save and advantage for us, but it's a huge stress reliever as well because we're not worried about doing that retreatment on a Friday afternoon before we leave and then sending the patient out. So, again, huge benefit for us. All of this is really just building trust and gratitude toward the practice, and it's building the reputation of the practice as well. So, what's going to happen? That patient has been told about Gentle Wave, they've experienced Gentle Wave, and now they want to go talk about Gentle Wave. So, this is where these positive reviews come into play. A lot of times they mention Gentle Wave without us asking them or prompting them to do so, again, because it's part of our system of care. They've heard it, they've experienced, they want to talk about it. And these reviews just amplify that awareness and then reinforce your credibility online. And what's it's going to do? It's going to create a very consistent positive feedback system. So just like that flywheel that we talked about, the social media marketing, the patient sees that, the phone script, we're going to introduce them to Gentle Wave, our story and our protocols, their registration process. Again, they get introduced to Gentle Wave. We're going to talk about it at the chairside consultation. They're going to experience Gentle Wave the day of care. And then at checkout, we're going to ask if they had a positive experience and then request a review. So hopefully at this point, this idea of the importance of systems and being systematic in your office is really taking hold because that is really what drives your efficiency in a modern endodontic practice. Again, it's not working faster, it's the systems that you're creating for you and your staff. And if you hear me say nothing else today, the systems you create today, I promise you, are going to save your sanity tomorrow. And with that, I think we're out of time. And I'm sure everyone's brain is full. One final thought, we began with the myth of speed. Efficiency is not faster hand pieces or a better file design. It's smarter system. Our tools are setting the stage, but it's our systems that are going to write your story. So my challenge for you is tomorrow when you go to work, choose one system, your schedule, clinical, Gentle Wave, and start laying the groundwork for those changes because even that little change will make a difference. And I promise you, your future self will thank you. All right. Thank you guys. If you have any questions, I would love to hear those.
Wow, Jonathan, thank you. I took a lot of screenshots. I'm sure that others did too. But I really liked what you just said. Even if I could incorporate two things here, I feel like my next week would be better. I'm going to get to some of the questions that are pouring in. One is when you place the sound seal in the proximal box and you use that
Mhm.
as a definitive restorative material, do you etch and bond that in place?
No. So if it's not going to be a definitive restorative material for us. Again, it's just a temporary restoration. You actually don't have to do the etching process with that. We're just using it as a temporary proximal wall. So we're just bonding it. You don't have to do the etch step. You can just do the bond step. but we don't want to leave that as a permanent restoration. It's not technically a filled resin. So if I were going to be restoring that case or sending it out, then what I would do is I would thin that back so that it's a minor shell, almost nothing left at all, and then use it as a matrix to create a composite restoration or a glass ionomer restoration. But I would not leave it in bulk the way that you saw it in that clinical case. That was going out as a temporary.
Sounds good. Could you talk about what type of obturation system you use?
Yeah, so good question. The primary obturation system we use is basically just using endo sequences, uh, the bioceramic sealer from Brasseler. We use the high flow sealer, and then typically it's just going to be single cone. We do a small down pack, basically the first 2 to 3 millimeters just to give the sealer a push. So we're driving it into some of that anatomy. Now, what I alluded to in that lecture was there are cases where you do that technique and then you take an obturation check film and you're like, that doesn't look good, or that doesn't look great. It doesn't look the way that I would expect. And what I've found in those cases is it's basically that we need to think about a different obturation technique. So we've got really great instrumentation tools now. We've got really great irrigation devices. Our obturation is where we're really lacking. So if you haven't read the article by John Stropcode that describes System S, it's basically a thermoplasticized injection technique. It has been modified for modern, procedures with bioceramics, but it's basically where we're using sealer and gutta percha to create a piston to drive it into the intricate anatomy and fill that space more predictably. It's terrifying the first few times you do it, but you really don't get overfills or, anything nefarious with that.
Great. Did you use that technique in that lower molar? That was amazing.
I
Yeah.
did. That was a System S technique.
Yeah. And what happens when a patient refuses a cone beam and if they refuse a gentle wave procedure? How do you tackle that?
Yeah, great question. So, our practice is not McDonald's. You don't get it your way. Gentle wave is part of our practice. If you do not want gentle wave, I'm sure there is a practice that would accommodate you. But I can tell you, since we have had gentle wave, I can count on one hand how many people have not wanted it. Again, because of the systems that we put in place, the marketing aspect, the phone call, the chairside education. Almost never does anyone not want gentle wave by the time we get to that stage. And then the cone beam CT, again, we are using that basically to make sure the patient is invested in the root canal. And what I mean by that is, and this is not to sound harsh, but we use it almost like an entry fee because most insurances are not going to cover the cone beam CT. So we charge $175 for the cone beam CT. And that's required. They have to take the CT and pay for it before they get on our schedule. Because if that patient cannot commit to paying for the gentle wave or the cone beam CT, the odds of them showing up for the treatment appointment is going to drop drastically, and that's where you get your cancellations. Once someone is invested financially, they're going to show up for that process. So again, until they take that CT and pay for it, they don't go on our schedule.
Yeah, when I heard you talk about the change that you made to do consult first and to do a gentle wave schedule, change is hard, as we get older, especially. Did you watch a webinar like this? What made you change? Who was your mentor? How did that occur?
No, so it was really just, as we brought Gentle Wave in, I think that the story that I told you, literally where I broke down and cried in 2017, that was kind of the make or break moment. I had already talked about to Adam, my partner, about our schedule and how I hated it and what could we do about it. And really, it was bringing in Gentle Wave that was that catalyst because we said, all right, if we're going to make this change, we're going to make that change too. And we did. We jumped all in. We changed everything about our practice top from bottom. So we went from two visit or multi-visit to one visit. We went from consult and treatment same day to consult required first. We changed our operation, we changed sealer, we changed everything. I don't recommend you do that. Pick one thing and change one thing at a time. It's a little less stressful. But in hindsight, aside from GentleWave, the schedule change is truly one of my favorite things we've ever done. And again, people that we talk to about this, if they come to one of our courses and they do it, they'll follow up and say, man, that changing my schedule is absolutely the best decision I've ever made. And it's hard, it's scary in the moment because it's not how most of us practice. But again, I think, we're professionals. Like you're in a professional setting. What other specialty can you go to and get care the same day? No cardiologist is going to do your open heart surgery today. No urologist is going to do your bladder surgery today. It's just not reasonable. Like we need to garner and respect our time and our expertise, and that's what the value of that consultation.
And how did you handle any pushback you might get from general dentists for trying to do consults first?
Yeah, good question. So with that one, before we instituted the change, before we brought in GentleWave and before we went to the consult-based model, we actually sat down and we created a letter on behalf of our practice. And that letter went out to all of our referring doctors, basically kind of giving them a heads up about what that change was. And then we kind of did some boots on the ground marketing where we went out and we talked to the front desk coordinators or the people that were actually calling the office to schedule patients and just let them know, hey, moving forward, this is going to be our priority. And, people always say, oh, well, you're not seeing same day emergencies. No, that's not true. We are seeing same day emergencies. The value of that schedule that I showed you, how I'm racing against the time block that we have in place, is that when someone is calling with an emergency, like I said, I'm not using that whole 70-minute period. My staff know my averages for the most part because of the time motion studies. They'll slip another consult in there or emergency consult depending on what procedure we already have pre-scheduled.
Right. What clinical situations have you found GentleWave to be more technique sensitive compared to many other irrigation methods you may have used? I'll say it again. In your experience, what clinical situations have you found GentleWave to be more technique sensitive?
I think technique sensitive, it seems like the thing that most people struggle with in terms of gentle wave, especially if they're not providing a lot of restorative care in their office, is getting a predictable seal. Like that's where most people struggle initially because maybe you're not used to doing those bonding procedures or really capturing a margin. I think that initial struggle period is short-lived. Eventually that kind of goes away. But in terms of, case type or contraindications, uh, I think that's really the only challenge is learning how to do a predictable seal and actually judge, let's say you build a platform and then it leaks, during that leakage test, is it an issue with the sound seal matrix that you created, or is it an issue of the restoration? And quickly identifying which of those two is the problem and then correcting it.
Sure. What are your protocols if you can't achieve apical patency?
Yeah, great question. Very first thing I do is I don't keep working the problem. So the worst thing that you can do is sit there and keep pre-bending files and keep pecking and pecking and pecking and just destroying your fingers. Um, Ryan Facer always said, and I love this, he said, patency's always there, you're just trying to capture it. So the easy situation for me is I'll instrument short of wherever I can get a hand file to and then run GentleWave. And again, that's when I use System S or that squirt technique method to capture whatever that anatomy is beyond that point. And I'm not saying that you can do that if you're, 8 millimeters back from the end of the root. That's not going to be predictable. I am saying if you're within 1 to 2 millimeters or it's a sharp apical turn, that's where a gentle wave can really shine for us.
Sure. Here's a question you did answer, but maybe answer it again. How long does it take for one case from anesthesia to completing the case using gentle wave? Maybe we'll say a molar or a premolar. Do you change your time depending upon the
Yeah.
tooth type?
Yeah, so again, that time is consistent on our schedule. We're not going to change that. I'm not going to physically change it. But in general, a molar start to finish, if we're doing restorative, is going to be right at 50 minutes. If I'm not doing the restorative process, it's probably close to the 45-minute mark. Now, if it's a hot lower molar or I have to wait or do a little additional anesthesia sometimes, that one's probably going to push an hour. It might push an hour and 10 minutes, depending on the case. But no more, but the vast majority of cases right at that 45, 50-minute mark.
Okay. This is an interesting one. Would you use gentle wave in a perforation on the root from a jaw screw?
Oh, yeah, like an implant placement.
Yeah. Or maybe orthodontic surgery, I thought. I'm not sure, where this person's question was, but
Yeah, absolutely. So, again, you read the contraindications. Perforation is a big no-no with gentle wave. So it depends on the location. If it's a fresh perforation from, a referring doctor and it's in the furcal floor, um, if you can get your floor adequately sealed and a seal to hold, so that's where you would, do your BC putty and then you would do some type of glass ionomer conditioning agent and then the glass ionomer, it should hold in that case. So yes, I would still run it. If it's a low perforation or a resorption case, it's well below, the gingival margin in the cancellous bone. You don't really have to worry. The fear is that gentle wave is this positive pressure device. It is not. It's all negative pressure. That's the scariest part for people to understand. It is negative pressure. I could pull up and show you plenty of resorption cases, like severe perforating resorption cases where we run gentle wave. When I say that there is no contraindication in my book, I mean there's no contraindication. And again, this isn't Sonendo saying this. This is me with over 7,000 cases. Every case gets shown away. There's no exception in my book.
Hey, Dr. Yules, uh,
Yes.
can I interrupt? I'm the one who asked that question. So I received this jaw fracture case that on the CBCT showed, I thought first initially it was resorption. Uh, it was on a number 27 young girl, fell off from the second floor. They went to do the jaw fracture. She came about 4 months later to me. And I looked at it and I looked, I said, something didn't seem right. And then I said, okay, this has got to be, they put the screw in the wrong place. So it looked like an external cervical root resorption. When I went to start the case, I just kept getting the wrong reading. And I knew obviously I'm off because my CBCT reading is different from the apex locator reading, which was 16 versus the length was 21. So I knew there's some sort of communication there. And that's when I said, I wonder whether I can run gentle wave on this because it looked really big. But
Hmm.
so that's my big question.
Yeah, I mean, personally, I wouldn't have any hesitation running it. Again, that's me. I'm not speaking on behalf of Sonendo when I say that. But yes, I would still run it. Again, there should be, bone or granulation tissue. There's something there pressed against that area. So it's not like it's just going to push out into the bone in that case. It's just going to be pushing against whatever's there, which should be some type of bone or granulation tissue.
Okay. All right. Thanks.
Hmm.
does your instrumentation expectation change when you are doing a retreat? That is, do you feel more compelled to make that curve or instrument fully in a missed secondary canal?
Um, Good question. So the instrumentation protocol does change slightly. So we're going to use basically uh, the Endo XP 3D shapers, what we typically remove bulk gutta percha with. And, my goal is always to achieve patency if we can, but there are cases, where they're just too severely damaged. It doesn't change what I'm going to do if I have gentle wave on board. As long as I've got the bulk of that gutta percha out, basically everything, don't leave residue in there. You can't leave bits and pieces and areas of gutta percha in place and then expect gentle wave to overcome that, and then you capture that anatomy, it's not going to happen. So, my goals are the same, but the instrumentation protocol differs slightly. But if I can't get patency, it's still the same. I'm just going to run gentle wave, and then I'm going to use, again, that system S obturation technique to capture the anatomy.
Okay.
And I've got a great case. If you follow me on Instagram, I've got one of these posted just like that description you talked about, where the anatomy, it had resorption and perforation. Beautiful. So go check me out on Instagram. I haven't been on in a while, but it's there.
Will you put that in the chat so we can follow you, your
Sure.
handle? Okay. If the patient is coming back for a second treatment, when do you use gentle wave? In the first or second appointment?
Typically, I'm going to use it in the secondary appointment. It's pretty rare. Most of the time, we're gonna, do things in one appointment. There are case types where you still have to do a two appointment process. If you run gentle wave and it's still draining, we're not gonna, just go ahead and fill those cases. Um, I will typically, depending on the case type, let me back up. Depending on the case type, if it is a retreatment case, I'm going to run gentle wave the first appointment. If it's a, necrotic, swollen case, true abscess scenario, gentle wave first appointment. But if it's like a pulpitis case, vital tissue, I'm going to reserve it for the secondary appointment in those cases.
Sure. Do you use the sound seal as a matrix for buildups?
Yes, yeah. So again, because we're going to do the pre-endo restoration, we're going to build that proximal wall that's missing. And then rather than the thick, proximal wall that I had in the image, I will thin that out so that it's paper thin with a slow speed burr, and then use that as the matrix for my composite core. Yes.
Great. Has gentle wave been shown to eliminate biofilms more predictably in the apical third compared to ultrasonic activation? And does this translate into faster periapical healing in comparison?
Yeah, there's several studies with gentle wave. Some of those are pilot studies regarding the biofilm. There are some studies that look at bacterial reduction. There was one at the AAE a couple of years ago. I can't remember which university that was from. But yes, in general, it's been shown to be more effective against biofilm removal. In terms of your healing, there's one study that we've got out, which I have some problems with. We won't go into that study, but it says that there's no difference between the two. I think that until we have really good long-term clinical data and a true randomized control trial with thousands of patients comparing these, and making sure that the treatment groups are equally allocated, it's going to be a tough question to answer and have a true response. You know, what I can tell you is in our practice, that post-op pain rate has dropped drastically. We tend to see faster healing of periapical lesions when it's occurring. The flare-up rate has drastically reduced. We don't get post-op pain calls, and those things have kind of gone away. The healing component is kind of hard for me to assess even in our practice because, like most of you, we struggle with recalls. We can put the patient down for a recall and and beg and beg and beg and beg them to come in, but it's really hard to get those patients to come back in, especially if they're driving or they're elderly. Um, and so the healing one I think is outstanding. I don't know if we have enough evidence, short of the 1 to 2 year studies that we have with gentle wave, but I'm talking about long-term healing and retention rates. I think that's still out. Even if it doesn't increase our success rate, the fact that it reduces our post-op pain and we don't have to take away as much tooth structure is automatically enough of a selling feature for me. I want that on my tooth, regardless.
Heidi's asking about the John Strapko article on System B. Do you know where that would be located? And if not, I can look that up and we'll send it out in the email to all of you.
It was in I can't remember which article. It might have been in Dentistry Today or one of those, but it's available online. If you just look up John Stropko System S technique, Google that, and the article will pull up. And again, you've got to modify it. That was for a time before we had bioceramics. So the emphasis at that time was minimal sealer, maximum gutta percha. Now it's kind of transitioned. It's more we're relying on bulk sealer and minimal gutta percha, with the gutta percha being the piston. So you kind of have to alter it a little bit. And that's one of the things that you can talk about or learn about in some of the, Sonendo 2.0 courses or some of the webinars that other clinicians have done previously.
Sure. So this one, the iPhone 186, if you want to come off mute and ask this, otherwise I'm going to give it a shot. But here we go, Jonathan. When you have a toroodontic tooth where bifurcation of a second canal is at the junction of the apial and coronal third, but cannot access, will gentle wave get into it?
Mm, yes, in theory. Again, I think it depends on case type. So, again, if it's a necrotic case and you've got a radiolucency, guess what? Gentle wave has to work way less because there's really not a lot of tissue there. You're basically killing bacteria and biofilm. Like that's the goal. So, if the space is present, it's got a clear path. If there's tissue in that space, I think it's going to depend on what are the other points of communication and that flow of fluid. So, if it's a vital canal with a lot of tissue in there, maybe you pick up and you do a second gentle wave handpiece, just to be overly cautious. In theory, it should. And I've had cases where I had a, great outcome, but I've had a couple of them where it was a vital case, and then I go to use that squirt obturation technique. And depending on the length and how vital that was, maybe it doesn't capture as much as I would like it to. So this is why you still need to be an endodontist to some degree. You got to keep bending those files to try to get into that anatomy as much as possible. Again, I think gentle wave shines in those cases where we're within that 1 to 2 to 3 millimeters of the apex. If you're halfway back from the root and it's a vital case, maybe, depending on the case type, but again, it comes down to time. It's one of those things where, ideally with the gentle wave system, we just extend that sodium hypochlorite cycle out. Maybe we spend a little less time with the EDTA, more time with the hypo in those cases. So that I think it's going to be case type on that one.
Great. This question I had, can you give us any small examples you were able to eliminate when you rewatch the videos of yourself working?
Yeah. So one of the things that I looked at was my access. Early on, it was my access because I noticed that that was an incredibly slow process for me. And part of that was, again, using that CT to kind of look at landmarks and plan out that access a little more efficiently. But there were little things that I would do, like, just, refining this or touching up that or trying to, make this a little bit better. And then in the big scheme of things, I'm like, why am I wasting this time doing that? That's not serving any purpose. It's not making the process easier or the tooth look better. Like, so I think sometimes, we get in our mind that we have to do this or we have to do that, and in reality, you don't. And I'll give you a good example of this. One of the things with making the platform for Gentle Wave, and I've seen clinicians do this, you make the platform, you take the matrix off the platform, and then you've got that little central hole within the tooth. Well, you should just rotate your mirror and see if you can see every canal within that tooth. If you can see every canal, guess what? You don't need to reaccess. That's wasted, inefficient time. If you can see the canal, the energy is going to disperse to the canal. Start gentle waving, eliminate that inefficiency. And then the other one I look at for, and really with the staff is the trade-off of materials and things. So it comes more into play early on when you're training an assistant. But again, getting them to see all the dead space. So you record that procedure and then it's like, okay, why are we waiting? What are we waiting for? Why is there not something in my hand? Getting them to see the value in that. But, I would say a lot of it is just like tinkering around or, doing things early on that just didn't make sense, like trying to get an estimate or trying to get an EL reading right off the bat makes no sense. Like I've got a CT, I know what the working length should be. Just go ahead and run the file as far as it'll go to that length and then go back and do the, EAL reading. So some of those things are, it's crazy what you'll find on yourself. And I think you'll be shocked when you're like, why am I doing that?
As if we rewatch this, we both might change some things, right?
Yes,
Yeah.
absolutely.
All right, so I am going to ask anybody to come off mute and ask some questions. Now's a great time. You do not have to come off camera, but please use this time to ask any questions.
Great lecture, Dr. Yules. Um,
Thank you.
I've been using it for a long time, but I don't think I'm using it to the utmost. I'm also in a very insurance-based
Yeah.
practice.
Same.
So we have to charge for CBCT and Genwave, and I have not been able to say, hey, if you don't want it, we won't do it. And I think that's an important step. I like what you suggested about your front desk and saying, we'll see if you qualify, because that then they say, oh, they want it more. They realize when they come in why.
Mhm.
Um, but I guess you and your partner have to be on the same page.
Yes. Yeah. And that's the standardization across the office. So we have 3 offices, we have 5 clinicians. And when I said standardize everything, I mean everything. Like we literally sit down as a group and we will ask the assistants, what does Dr. Yules do versus Davis versus Arsu versus Depose? And whatever there is some discrepancy, we have a discussion and we eliminate whatever that discrepancy is. So whether you're getting a root canal from me or Dr. Davis, the process and the product should be the same. It's a
Yeah.
Cumberland endodontics root canal, not a Dr. Yule's root canal, basically. So that's kind of our mindset when we're looking at it. The other thing, we're insurance based too. So 70% of our office is going to be insurance based. Um, we tell patients up front the CBCT is generally not covered by your insurance carrier. It's $175. You're responsible for that today. We will submit it on your behalf, but they typically do not cover it. So we kind of prepare them for that portion.
Yeah.
Now, as part of their registration, there's also a gentle wave consent form. So, if you're insurance based, and this was one of the things we struggled with initially was, you submit the gentle wave code off to insurance and they're going to deny it or they're going to
Yeah.
reimburse you $3 for, something that cost you $125. So that didn't make sense for us. And one of the things that we realized, in talking to some other clinicians, if you go into a general dentist and they're going to do like a big restorative arch case, they're not going to use their same lab that they might use for just their typical crown. Like they're going to have a lab upgrade fee. And so we kind of use that working with our attorney. And so we have a separate form, gentle wave consent form as part of our consent packet. And it basically lays out in there that we will use the gentle wave system, assuming that they're a candidate, which everyone is a candidate in my book, and that there will be an additional fee of $125 for that procedure, and that it will not be billed to insurance because it's outside the scope of the insurance policy. So, we lay it out. We had our attorney look at it. We sent it to some of our carriers. So we put the onus again back on the patient that this is their responsibility. And again, even with that, where we're charging because we can't, we absorbed that cost for the first several years. And then, of course, 2020 happened. And I think we
Yeah.
all know what happened to our operating costs.
Oh,
Staffing costs
yes.
went up, operating costs, like everything has exploded in cost and we just
Yeah.
couldn't absorb it anymore. And so it's either we eliminate gentle wave altogether or we find some way to make it work. And for us, that was the solution was an additional consent form in our registration packet.
Great. Yeah. I mean, I already have that additional consent form, but I haven't. I worked with somebody in Sonendo years ago, but I had not shown it to a lawyer. But they are upfront we tell them this is what it'll be, and we will not be sending it to insurance.
Yeah,
So they're
good.
aware, but I don't have anything where um, it's, I guess we have to sort of create something, let the lawyer look at it. One last question, policies. Do you share any of your stuff with policies with Sonendo, and Sonendo create a general template that they can share with all their users?
We don't have anything shared right now. I think I've shared a couple of GenoWave related things in the past in lectures. If there's anything specific that you want, you're more than welcome to, email me directly. Um, that
And
is might be one thing that I could look at doing is, creating some type of systems packet or something for you guys.
Also, do you have, I heard you saying you have, so first I need your email. The second is you said you do a workshop uh, in your office where you bring in people.
Yes, so we do on behalf of Sonendo, we do a 1.0 and a 2.0 course. And you get a lot of this information that I talked about today is in that 1.0 course, some of it, I should say. But the first day, the 1.0 courses are basically introduction to GenoWave and how to use a mechanism of action and integration. So you get a lot of this integration concept within that. And then the 2.0s are of course, where we do like the obturation technique and more about instrumentation and adequate platform building and those things. So it's just one of the Sonendo 102 or courses.
I have a
so
question.
go ahead.
Well, first of all, thank you very much for your presentation. I want to ask you something. I've been using the system for 4 or 5 months, and one of the steps that I really spend time in is in achieving a dry canal.
Mm.
I see so much, but lots of bleeding after running the gentle wave. Um, is there any recommendation for this?
Yes, don't get a dry canal. There with Genoway, are you using CleanFlow or the Molar PI?
Clean flow.
Okay, good. So, with CleanFlow, that bleeding overall should be less, but are you using a bioceramic sealer?
Yeah.
Okay. So this is one of the big mistakes people will talk about. They don't see as much anatomy, and it's over drying or desiccating that tooth post gentle wave. So remember the bio ceramics, they have an affinity for moisture. So leaving a little bit of moisture inside the tooth is actually going to help to drive it into that anatomy sometimes. So, and I don't mean like you pull out the paper points and they're completely soaked in blood. That's a no-go case. If you've got that type of bleeding post gentle wave, which is, generally pretty unusual, in those cases, you could use something like peroxide to rinse the canal, reduce the bleeding, and then dry it. But it shouldn't be desiccated. So you need some moisture in there again to help the bioceramic set. So a little bit of excess bleeding in the canal when you're obturating is not the end of the world. And I mean like 1 to 2 millimeters on the end of the paper point. Like don't keep picking that area because sometimes you're just going to create more bleeding again.
Okay, thank you.
Mhm.
So we do post this video and it will be up. It usually takes about 2 weeks. It'll be on the VIP portal. We also put it on YouTube. I think it's going to be highly watched. I'm getting some personal texts already, Jonathan, on when that is going to be up.
Good.
I did take a lot of screenshots. I did post my email for anybody on the call right now that wants to reach out to me for anything. I have many examples from many of our users on a lot of the questions that people have been having. So thank you for that. And just what a great night. It went so fast. I can't believe it. Um, but I know that the staff would really love to watch this too. We do have our last month's webinar that just got posted, and that is on troubleshooting for the dental assistant. So it's very, very another wonderful presentation to look at. So make sure you watch that one too. I'd like to show everybody what is coming up next. So our next webinar again is October 15th. It's the every third Wednesday of the month. The next one will be with Dr. Michael Ribera. He is full of energy and has a great gentle wave story himself. He will be talking on enhanced irrigation techniques and endodontics, how to achieve a differential advantage. Feel free to take a picture of the QR code. You can sign up on our website. You can contact me. We do email this all out to everybody before the webinar and how to sign up also. So again, thank you tonight. A few minutes late, but it was just an enjoyable evening. I hope everyone has a nice evening and can start tomorrow with a few tips from tonight's webinar.
All right. Thank
So
you, everyone. Thank you for the chance to talk.
you're welcome.
Thank
It was a
you.
great
Have a
night.
good
Thank you,
night.
Jonathan.